Welcome back to the podcast. This is part 2 of my series with Bonnie Boenig, and today we're going right into a topic that tends to feel confusing or even controversial in pediatrics, manual therapy. A lot of clinicians either avoid it completely or they assume it's only for certain providers, or maybe they worry it isn't evidence-based enough and they didn't learn it in school. Bonnie teaches on this topic and has multiple certifications in manual-based approaches. What I love is that she doesn't talk about it as a magic trick. She talks about it as one part of an integrated plan that supports function. So in this episode, we're going to define what manual therapy is, what it's not, and why it helps kids, and how clinicians can think about it in a practical, grounded way. Hey there, and welcome to Connect the Dots Learning Center podcast. I'm Stephanie Wagers, your host, and I'm so glad you're here. Whether you're a seasoned therapist, clinic owner, or just starting out, this podcast is your go-to spot for insights, tips, and stories that'll help you connect the dots in your practice. Welcome back, Bonnie Boenig. We are kind of moving on from last week where we talked about how to blend therapy and lenses. And today we're going to talk more specifically about what manual therapy is. Actually, what does it look like in pediatrics, what it is and what it isn't, and what types of kids that it can help with. You say manual therapy. What are you actually referring to? And what does that look like with kiddos?
Sure. I use manual therapy in a broad sense, in broad terms. So for me, when I'm saying manual therapy, I'm thinking about hands-on strategies that really help to reduce restrictions and to increase freedom of range of motion, really to prepare the body for active functional movement. And so included in that are myofascial release techniques, other soft tissue strategies. Craniosacral therapy is a hands-on manual therapy, but all of them are really used in combination with other approaches that facilitate active movement and function. So I think, they're just more directive in terms of gaining range and reducing restriction.
What do you think people get wrong when they think about manual therapy?
I think a lot of people think it's a passive technique.
Mm-hmm.
When you think of manual therapy, sometimes I think people envision somebody laying on a table with hands-on, like massage. Truth be told, there are times that I do that with a pediatric client as well. I'll lay them on a plinth and do some passive directive, so strategic kind of work around certain joints to free up joints, or within the trunk and the musculature that supports posture. Oftentimes we have children that have weak postural systems, and a lot of that is connected to the restrictions that they have in the range that's accessible to them, because they can't access that. They can't access the musculature to work in the way that's necessary to support and movement because of those restrictions. So I think that maybe, I think that's probably the main misunderstanding is how is this really going to help, support movement and function when you're laying somebody down on a table? That should not be the whole session. That should be really specifically, you're using that for a particular reason, and then you move on to function and strengthening and postural work.
So you said something that kind of made my ears perk up a little bit with postural stuff. So we see a lot of, sensory ADHD kids, autism that have a lot of core instability. So what would that hands-on approach look like? Can you kind of give us a visual of that?
Sure. I use my hands-on approaches with those children the same way I do with children that I work with who are stuck in wheelchairs for 8 hours out of the day. And I think one of the things with those children that come to us with self-regulation issues and fine motor control issues, handwriting problems, and not being able to tie their shoes, attention focus issues. A lot of what I see when I take a shirt off and really look at the whole body and alignment is there are a lot of shifts in alignment that really produce restrictions in the trunk, around the spine, and up through the neck and the shoulders where tension and emotion kind of lay.
Yeah.
And so it looks the same, really. I mean, I work from a medical model, and I know that school-based therapists really can't do this, but then that's why it's so important to do collaboration between medical model and school-based therapy. Because
Hmm.
in a medical setting or in a clinic setting, we can do this. Parents right there, we talk through it, we can make
Right.
them understand why we're putting hands on, but it really does look similar. I mean, I can give you an example of
Yeah.
one child that I worked with and still working with. This child has been in therapy since he was born. He did not go through the typical developmental milestones.
Mhm.
He was a little bit delayed in milestones. And when he did acquire those milestones, he really had trouble with coordination and
Mhm.
strength and, jumping and, getting himself off
Right.
the ground. So when they came to me, it was about emotional outbursts. In middle school, he is he has difficulty focusing. He has
Mhm.
diagnosis of ADHD, and so I did a full-blown assessment, took his shirt off, and the before and after pictures right now are just pretty
Wow.
amazing. So what I saw and the parents saw was pretty much a functional scoliosis that
Okay.
also had rotation included. And that was really causing his foundation for stability to be very weak and inconsistent. So when
Hmm.
he's sitting and doing fine motor work at a table, he's really challenged by not having good postural strength, and he's thinking about staying up instead
Yeah.
of concentrating on what he's doing with his hands. And of course, we know that that also influences the coordination and the actual selective function
Right.
of wrist and hand and distal function. So the first thing I did with him was I did a little intensive and really focused on getting alignment through his trunk, and not for the entire session. So I'd have like a 90-minute session, and I
Yeah.
did that maybe for 30 minutes, but then we would bring it into movement and strengthening kinds of work. And the parents were given some stretching exercises to do.
Hmm.
And
Hmm.
so, 3 weeks later, he's in a different spot now. We can focus more so on the actual functional goals of handwriting and
Hmm.
tying shoes and
Hmm.
emotional regulation.
Yeah. So you're working on the underlying
Yeah.
cause and the foundation. Yeah.
Yeah.
So where did you learn your skill sets from?
So I was really fortunate, I think, to become aware of
Hmm.
faster release and some of the other manual therapies early in my career. So right
Hmm.
after I was NDT trained, the OT that was my instructor was also very interested in myofascial release, took some Barnes courses, John Barnes
Yeah.
myofascial,
Yep.
and really kind of introduced me to that, and I got really excited by it. It resonated with me. I think there's some therapists who shy away from some of this work.
Yeah.
It's not natural to touch but we all have different sensory systems, so I think that plays into it. But it resonated with me, and I really, really saw the benefits. And I also saw how it integrated so well with NDT
Hmm.
because getting rid of some of those restrictions with quick kinds of results, and then elongating that tissue and really bringing those kids through some developmental functional milestones and positions really helped. So I took Barnes courses. I
Okay.
also took courses from therapists who integrated it with NDT. So I
Hmm.
learned that part of it. And then I went on to a Pleasure Institute and did some craniosacral therapy. I saw the value to that with regards to, and I don't know if
Hmm.
everybody knows craniosacral therapy or, with what that's referring to, but I was most interested in the visceral manipulation part of that because of the link to a lot of the kids that I worked with that had gastrointestinal kinds of issues, eating issues, and all the gurping that happens.
Why do you think then that, because all of those craniosacral burns, all of that, yes, I was very much into that stuff as well. Why do you think that providers now shy away from manual therapy or not doing these courses?
I don't have knowledge that that's the actual. Do you think that people are shying away from?
I do. I'm just thinking about, when you said you haven't had him take his shirt off, that is something that
Mm,
often is not done in,
that's
that
true.
they're listening to the parent, they're hearing, this and that about the child, but they're not
Right,
looking structurally at the foundation.
right, right. Well, I think when we spoke the last time,
Hmm.
we touched on some of that. I think, the curriculum in the universities
Yeah.
don't offer a lot of that. I mean, in my curriculum in my university, I did a lot of work together in courses with PTs. So
Hmm.
that was the manual work. I learned mobilization with the PTs. Now I don't
Okay.
use that a lot in pediatrics,
Yeah.
except for some general work, some very gentle work. Um, but I think it has something to do with the university curriculums because OTs in our curriculums too, because of the population shift to having so many children come to us with diagnoses of autism
Hmm.
and difficulty with self-regulation and emotional kinds of connections and mental health issues. I think that we have other approaches that we tend to move to first
Right.
to address those concerns, like you said, without really appreciating that maybe there's a foundational
Hmm. Hmm.
piece to that needs to be addressed.
Yeah. So let's talk about fascia. Just for many people, they may not think about fascia in treatment.
Hmm.
What role does that play in, like, let's say with a child with autism?
My goodness. How much time do we
Let's say toe walking.
have? Yes, in a child with autism, it's no different, really. The sensory piece might be the initiator for what we're seeing in terms of symptomatology, but then or characteristics. But the reason then why that's persistent is because of the shortening of the fascia that happens and the laying down of that fascia to restrict that movement. So when I teach my fascial courses, I mean, one of the things that we have to understand about fascia is that it's this weave and web throughout the entire body. It's a connective tissue network that supports
Mhm.
everything. And so
Mhm.
it supports muscle and intertwines with muscle. It supports organs, and it's the system that is responsible for laying down scar tissue,
Mhm.
and it's the system, therefore, that is also respondent to postures or functional positions that we use over time for whatever
Mhm.
reason. So the fascial system, is pretty perceptive. And if we are sitting on one hip all the time and getting a shortening on one side of our body, then the fascial system is helpful. It says, well, if you want to sit like that, then we're going to
Let me
help you
just tighten that up.
shorten those muscles and shorten that area for you so you don't have to worry so much about, maintaining that position. Same is true then with tight hamstrings and tight Achilles. And so kids that are toe walkers, obviously we know that there's a sensory component to that, but then over time, there's a restriction that lays down in the Achilles and the musculature around the back of the heel and up into the calf, and then further up than that, because the fascial system, when
Right.
you're
It's all
talking
connected.
about working on the foot, you're affecting something near the cervical region of the spine.
Yeah. So how do you know what manual therapy tool is the right one to use versus, doing something different? Like cranial versus fascial release,
Right.
versus
Right.
mobilization. How do you know when to use what?
Well, I think like any other approach, we have a sense of that through experience, and then also we start with something.
Mm.
So we have all these tools at our disposal. Usually when I see shortening of tissue that is holding a postural kind of a malalignment, or is restrictive, say restricting wrist extension for good use of, or pronation, if the child is really struggling with handwriting and he is approaching things with a thumb down and never really got that good control of neutral supination, start thinking about, well, there's probably some restriction in that interosseous membrane between the ulna and the radius
Mhm.
that really needs to be worked on and
Mhm.
move towards soft tissue kinds of strategies, and then maybe myofascial release. Myofascial release, I tend to move to when I'm thinking and assessing, and I see that there's really a connection, full body.
Mhm.
Oftentimes when I'm using myofascial release, and those of us, those in your audience that are listening who know myofascial release will know that sometimes there's a somatoemotional component to that.
Yeah.
And so if I hear in the assessment that there's that component of emotional kinds of instability and dysregulation, and then I see a lot of postural stress and postural malalignment, I might go for a full body kind of approach where I'm hoping to really free up restrictions globally instead of specific soft tissue strategies that would free up a supinate an ulna from a radius.
Right.
So sometimes it's how broad I want to go.
Mhm.
Sometimes it's whether or not I'm integrating it into movement.
Mhm.
So doing some nice elongation along the side of the trunk through an NDT type of approach to get
Mhm.
some nice postural weight
Mhm.
shift. I can integrate myofascial release there really
Mhm.
beautifully. A lot of it has to do with clinical reasoning again.
So
Like
when
what
you're
am I
talking
used
about that
to?
that whole body release, you're talking more about craniosacral therapy.
I mean, it's really hard to separate those two, to be honest with you,
Yeah.
because yes, the craniosacral, there are certain techniques in craniosacral therapy that work more with osseous kind
Mhm.
of changes. So skull movement
Mhm.
and craniosacral fluid movement. I mean, tapping into that piece. But when Upledger discovered craniosacral rhythm, it was because as he was doing a dissection for a brain surgery, when he was doing a dissection, he felt that pulse, not through the muscle, but through the fascia. So it's really hard to
Yeah.
separate out fascia from or fascial release from craniosacral, and a lot of the cranial, other than cranial 1, cranial 2, cranial 3 even started getting more into the fascial realm. The offshoots from craniosacral work, such as visceral manipulation, where you're actually releasing fascia around organs, is very much offshoot from craniosacral work, not from John Barnes' work. John Barnes' work
Right.
was really more PT related in terms
Mhm.
of looking structural, and
Yeah.
how we can impact structure.
Fascinating. So what I'm really hearing is that we need to really blend all of our approaches. I mean, you said it beautifully when you're saying that, you're doing NDT or elongation during side sitting, and you could have them on the swing. You could be doing all these different things. So
Absolutely.
yeah, really, I think opening our eyes and going back and looking at the structure of the child and what
Mhm.
does that tell us?
It
Yeah.
really is. It's an approach that allows us to specifically address muscular restrictions that
Mhm.
impact joint freedom of movement, that impact, obviously, the ability to selectively use those joints and to have stability and coordination of movement around those joints. As OTs, we often are focused on distal function, but
Right.
we know that proximally you need stability and activity,
Hmm.
functional activity. I'm talking about the shoulder girdle to the hand. We need to address that foundation to get good distal function.
Right.
And I see this as just another approach, not to use in of itself, but
Right.
to blend and integrate into the whole picture.
Yeah. So let's talk about, a newer clinician or even a seasoned clinician that doesn't really have this experience.
Sure.
Where would be a good place for them to kind of start, kind of where they might feel safe? Because I can hear a lot of OTs might be like, well, this isn't OT, this is PT.
Right, right. Yeah. Well, it's within the OT scope of practice,
Hmm.
and it's OT as we apply it. So we're applying it primarily to reach our functional goals as OT. We
Right.
never let go of that functional goal. It's just another way of doing it. So I would say, I teach myofascial release, and I teach it as an intro course, and then I teach it as a combination with NDT, and I
Mm.
also have some blended courses that bring in SI. I think OTs generally, if it's something different like this that they see outside of the scope of what they've learned in the past, or it might be more leaning towards, say, a PT kind of a orientation, feel safest learning from an OT because
Mhm.
we put it into the context of how we bring this into our practice as an
Yeah.
OT. And there are other OTs that are teaching this, not
Right.
just myself. But I would also say it's important to really make sure that you're hearing it from somebody who has a strong foundation in the basics of
Hmm.
myofascial release. And
Hmm.
for that, you might want to take a Barnes course.
Right.
That's where I started for sure.
Okay. Okay.
And so, yeah.
Where would one find like one of your courses? Are they
So,
online?
yes, they are going up online soon.
Okay.
I have a whole host of courses I'm reaching out to and hoping to find some facilities that would like to sponsor a few of my courses. I've kind of gotten away from that through the role that I had for many years. But I would like to get back into doing more of that. So I have a few courses that I am teaching here locally in Ohio. Yes, they are going up on my website soon.
Good. That's exciting. So, what happens with our profession when we really kind of lose that hands-on approach to therapy?
Honestly, for me, the hands-on uh, an approach includes for me like every approach that we use. I mean, sensory integration,
Hmm.
NDT, manual therapies, but I think if we relegate ourselves to sitting across the table and doing fine motor practice, that limits our scope and it also limits our successes in terms of
Absolutely.
positive outcomes. Our profession is designed to really look at the child as a whole. And because we do that, we really need to, I believe, have approaches to deal with the the aspects that are interfering with
Hmm.
the function that we see. So, that one example that I talked about with the young man that I did 3 weeks of like hands-on with, I wasn't ignoring his other needs, and we
Yeah.
would spend some of the time doing that. But one of his main things was the goals was tying shoes. He'd been working on it for 11 years, and he last week tied his own shoe. So
Awesome.
we didn't access that every single time I saw him,
Right.
but it was everything that came together. So there are times, obviously, that we sit down at a table and we do practice, and as adults, we need to practice things in order to become masters and to
Yeah.
master that functional task. But if we only use practice, we are limiting our ability to really have success and to
Mhm.
achieve outcomes. The other thing we're doing is limiting ourselves in practice as OTs.
Right.
Our practice narrows, then
Mhm.
we're thought of as the the
Fine motor
professional
person.
that sits at the table and practices handwriting.
Yeah. Which is the furthest thing from the truth, right?
Exactly. Right.
Yeah. That's beautiful. I love that. Well, I know next week that we're going to bring kind of all this together and we're going
Yeah.
to talk about how do we translate progress in the therapy session and make it work at home
Yeah.
because, we need to make sure that what we're giving the parent can survive those Monday morning routines. So next week we're going to talk all about that. We'll probably talk about how you're able to teach parents how to blend these approaches and make them
Mhm.
stick at home.
That is a key thing. That is just a key. I know that you speak to parent coaching and
Mhm.
teach parent coaching, and yes, it's a primary area that we need to involve ourselves because we often, I think, historically have given parents lists of things that they need
Mm.
to do at home, and we as parents and as moms and aunts and
Yeah.
whatever, we see what real life is at home. We have to be careful that we're not overburdening because then the important things just don't get prioritized.
Well, I'm excited to dive into that next week. I appreciate your time
I am
today. It
too.
was super fun to learn about manual therapy and kind of brought me back to my roots.